So good morning, everyone, and welcome to our 24th annual Simon Bernstein Visiting Professor in Minimally Invasive Surgery, our hybrid round. So we are here live in the Osler Amphitheater, first time since its renovation. And I know that many of you are joining on Zoom, so we'll see how this works. So it's really my pleasure to introduce our speaker this morning, and we've had a great visit so far, a full day yesterday of all sorts of wonderful activities, and of course our research presentations in the afternoon, and a really inspiring talk yesterday. And what I was just really struck by is, I mean, I've always seen you, and I guess I should introduce you, or your name is here. It says Dr. Michael Ujiki, who's our visiting professor, who's the chair of innovation and program development, vice chair of clinical affairs at NorthShore, professor of surgery, and I'll get into more of the details later. But I think, I mean, I've always seen you as an innovator and a pioneer in endoscopy and all, like all the sort of creative ways that we sort of try to treat patients and with less intervention. But despite being very innovative, we're also very thoughtful about the approach. And yesterday I really saw, I mean, how you really gather the data and really try to be do right by our patients, and really understand what is the role of this new device and how can we really use it to help our patients. And I think we can all really learn from that and be inspired by that. And I'm really looking forward to hearing what you have to say about gastroplasty as well, or endoscopic sleeve gastroplasty. I've also been very struck by your sort of commitment to education over the years, and it's just been really inspiring to see how humble you are despite all of your amazing accomplishments. Dr. Ujiki was awarded the SAGE's Jeff Ponsky Master Endoscopist Award recently from SAGE's, has been involved in many different aspects of that organization, in addition to the Foregut Society and many other surgical societies. Your contributions have really been really, I think, have made a difference in how we treat patients, specifically with foregut disease and other GI diseases. So it's been an awesome visit so far. It's been great to get to know you and to spend some time with you and learn from you. And we're all looking forward to your talk today. So I think I'll let you go ahead.
Yeah, thank you, Melina. This has really been unbelievable trip, and it's really exceeded expectations. I've been excited since the day that I got the invitation, and it's been not just a little, but tremendously better than I would have expected, and I was expecting a lot already. I've learned that first of all, you have an amazing group of fellows and residents. Aziz not only has been so generous with his time away from his family, driving me around, but talking about cases, I can tell that he's already a wonderful doctor, but it's really going to be an incredible attending. I learned that you have a fascinating and really impressive and spectacular collection at the Osler Library. That tour was really educational, and we saw relics from the 14th century, and I just really enjoyed that. I learned that you're doing unbelievably great clinical research that I've read for years, and now I was able to experience it yesterday. And again, it's something I already knew, but just seeing the residents present your work and all of the attendings and the thoughtful way in which you are approaching patients with really moving the needle in terms of getting people home same day. I cannot wait to take a lot of what I learned home. This
Maybe that's why I have a headache, because you had so many
I've learned a lot there. I learned that Melina is not just a spectacular surgeon, which we all know, spectacular educator, but is really great at choosing fantastic restaurants. And I learned that your sim lab, which again, your sim lab has always—
You got out of bed and went back to Edin's bed.
One in which we all aspire to be. Seeing it, in person, And having that tour with Dr. Free yesterday really blew my mind. You guys have unbelievable resources, and the commitment to education and surgical simulation is, again, it continues to be what we all are going to continue to strive for. I learned that if there's a lot of wine and you sit next to Lorenzo, you're going to have a great conversation, but pay for it the next morning, which is where I am right now. And so this has really been a fantastic trip. So I really appreciate it. And I'm just going to talk a little bit about endoscopic bariatric procedure. I am a MIS surgeon. I trained with a gentleman by the name of Lee Swanstrom, who at the time when I arrived, I saw things I had never even dreamt of. We were making holes in stomachs from the inside, going out, getting gallbladders. And I realized that endoscopic surgery is really kind of the next frontier for us in surgery. And since that time, it's become and continues to be a research interest of mine. I think this does apply to not just general surgeons, but we have a lot of interest from other specialties, orthopedics, for example. We know that hip replacements, joint replacements will have better outcomes if we can get patients under the obesity range. When it comes to gynecologic cancers, urologic cancers, again, anything we can do to quickly get weight down in a safe way that doesn't really require a lot of recovery is important. And so I hoped that this might be something that was relevant for a lot of different specialties here. Oops. I do have some disclosures, but I don't think that they are really relevant. I will just say that Apollo, which was recently purchased from Boston Scientific, does make the device that we are using for this, but I don't personally gain or profit in any way from that. Now, these are United States statistics, but I do think that it's probably applicable to the Western world in general. But we all know that obesity is a problem. It's tripled since the 1970s, but I think even more concerning is the increasing incidence in adolescents. So this is a problem that's not going away anytime soon. And so we really need to think about ways in which we're going to approach this and help our patients, because we know, and I don't need to talk to anybody here about it, but all the ramifications of obesity are pretty tremendous. And I think it's difficult to lose weight, especially in the US. It's not set up well for people to lose weight on their own. And as a matter of fact, only about 10% of patients can lose a significant amount of weight, just 7 to 10% total body weight on their own, and then keep it off. And why is that important? Well, if you just lose 7 to 10% total body weight loss, we already will see a significant improvement in comorbidities like diabetes, hypertension, high cholesterol, sleep apnea, reflux, even depression. So that 7 to 10% total body weight loss doesn't sound like a lot, but it actually does have a significant impact on our health and quality of life. Unfortunately, 1 out of 10 people can achieve that on their own. So we do need ways in which we can fix that. And fortunately, these days, we have great, as the bariatric surgeons know, we have great modalities to treat obesity that are not just very successful, but actually the morbidity rate. And there was a publication recently that showed that if you look in, I don't know if it was NSQIP, it might have been MBA-SQIP, but the morbidity rate was actually equal to a cholecystectomy for gastric bypass and sleeve gastrectomy. So I think there's no reason to fear these great surgeries where we see really good outcomes, really low morbidity rates, low mortality rates. So we can do a lot. The bariatric surgeons know this. A lot of other doctors, however, don't realize this. And so in the United States, only 1% of eligible patients actually have surgery. That's a tremendous statistic. 99% of the patients eligible for bariatric surgery don't get it. There are a lot of different reasons for that, but a lot of it are the misperceptions in the morbidity rate of the surgeries themselves and the long-term outcomes. But interestingly, we actually polled our primary care physicians in our healthcare system. So we have, I can't remember, maybe 2,000, 3,000 doctors, most of which are primary care physicians and referring physicians like endocrinologists. And we asked them, about their perceptions on bariatric surgery, their when they think about referring patients for it, why they wouldn't, what they think about taking care of patients afterwards. And first of all, less than 50% knew what the guidelines were for referral or for indications for bariatric surgery. And a lot of a lot of primary care physicians reported concerns over complications, and a significant amount didn't even know what was really available. So, and the interesting thing is that a patient is 5 times more likely to have surgery, bariatric surgery, if their primary care doctor endorses it. So even if a patient is thinking about it or interested in bariatric surgery, if they don't have their primary care doctor supporting it, they are not likely to have it. So we have good options and modalities to treat obesity. However, we have some misperceptions out there, both by patients and other doctors, about the surgeries. And so we need to think about some other ways that we can fill that gap. There are diet and exercise. And the one thing I don't have on here is medications that I'll get to at the end. But we have other things like the balloon, which is okay in terms of weight loss, but not great. And then obviously the surgeries are very good, but they're a little bit more invasive. Barham Abu Dia, who I learned how to say his name right. I've known him for years, and I've been saying his name wrong the whole time, but Aziz corrected me. So he was the first to publish this. He was a Chris Thompson grad at Brigham and Women's, and Chris Thompson was really kind of the innovator with these endoscopic primary weight loss procedures, but Barham was the first to publish it. And what they did is they did 2 parallel anterior and posterior suture rolls with a kind of a novel endoscopic suturing device. And what they saw was some actually significant weight loss with this, and again, very safe. The procedure, however, he said took 9 hours, the first one that they performed. I had heard about it. I was a little bit skeptical, to be honest, as a surgeon, a GI surgeon in particular. We purposely put sutures like at the pylorus, for example, knowing that they're not going to last when we do pyloric exclusion. So I thought this is something that will kind of come and go. And I didn't really jump on board early. I did, however, follow the literature closely over the years to see if it was, kind of what I thought it would be, or was it something that might surprise me. And I started to see over the years that there were similar results across the world. There were a few places doing it in Spain, in the US, and at Brazil. We started to see similar results. And actually, even as we got out 2-3 years, we're seeing those results kind of persist. This was one meta-analysis that had over 2,000 patients. And again, what we expected was a low mortality, low morbidity rate. What I didn't expect was to see a pretty impressive total body weight loss of about 17% and a 73% excess weight loss. I mean, this is on the lines of bariatric surgeries. And as you can see here, we're out to about 1.5 years, and we're seeing pretty persistent results. So at that time, about 2016, we started performing the procedure. It was difficult to do it in a high volume, even though we had a lot of patients that wanted it, but we didn't have any insurance coverage. So it was clearly just something that could only be performed for patients who could pay out of pocket for it. And at that time, we started talking about a randomized trial so that we could get some really good level 1 evidence as whether or not this was a procedure that should be done. So again, Barham at Mayo Clinic put together the trial. It was actually very good. At the beginning, there were 6 of us, 3 surgeons, 3 GIs from across the country. And eventually we got 9 centers on board, 5 GIs, 4 surgeons. And what we looked at is multi-center. It was prospective, it was randomized. So patients were randomized 2-to-1 to the procedure or weight loss counseling with us monthly, and with diet and exercise counseling. The patients, just for ethical reasons, had a opportunity to cross over to a year if they wanted to and didn't have, for example, significant weight loss with the diet and exercise program. And the purpose of the study was to really evaluate the not just the efficacy, but also the safety. And we were shooting for about a 25% excess body weight loss at 12 months, a 15% excess versus control, so 15% above control at 12 months. And we really were shooting for a adverse event rate of less than 5%. And Eric Wilson at University of Texas was the primary with Barham, and he was the surgeon that was there. We also secondarily wanted to look at, obviously, comorbidity resolution or improvement. And these were the results of the study. So first of all, in the middle of the study, the FDA actually took over. So this was basically an FDA study, which is, if you, I don't know how it is here, but in the US, it's a pretty rigorous study. And they come and look at every little detail of each case, and we really have to be very exact in our record keeping and so forth. And so this was a kind of a big deal. It was a lot of work. And so for that reason, I think a lot of centers that may have been doing the procedure but couldn't do it because they didn't have the research resources to do it, because this really kind of took all of our focus actually for a couple of years. It was hard for us to focus on other things. But we found some pretty impressive results. So we had a 50% excess body weight loss, which was about 32% more than what we saw with the medical weight loss group at 12 months. And we doubled our target. Our target was just 25%. We got to 50%. We saw a 45% difference in excess weight loss compared to the medical treated patients. We were just looking at a 15% difference. And we saw about 80% of the subjects achieved at least a 25% excess body weight loss. So, that's pretty good. The bariatric surgeons know that, that's something that we shoot for these, for kind of major surgeries even. And so we were pretty happy. And if you look there, the red line is the diet and exercise group. And at 1 year, they were allowed to cross over, and most did, not all, but most did. And you can see that, even the crossover group came up and had similar results. The 2% adverse event rate, honestly, as a surgeon, there were some adverse events that I would not count as adverse events. So for example, we saw 6 patients that were admitted instead of going home same day. They were admitted for like nausea from the anesthetic, and that was counted as an adverse event. I mean, for us, I don't know, we didn't really think that was anything significant. We see it all the time. Even the one bleed in the whole study didn't require a transfusion, but that was counted as an adverse event. And there was one perigastric abscess that was aspirated endoscopically, treated with antibiotics. The malnutrition patient was at Mayo Clinic, and the word is it wasn't really related to the procedure itself, but because of other reasons, being malnourished, they reversed it because they didn't want any kind of restriction or any weight loss from the procedure. So I would argue that we didn't really have any major adverse events, but of course, in an FDA study, even every little thing is counted. So bottom line, very acceptable adverse event rate. We did, as expected, see improvements in a lot of the comorbidities. Interestingly, we didn't see a really huge improvement in hyperlipidemia, which was kind of a surprise, because as bariatric surgeons know, that's one we typically see pretty rapidly get better when we do bariatric surgeries. But we did see 35% partial or complete remission of diabetes. We saw 45% improvement, 20% complete remission actually in hypertension, and we saw a significant improvement in quality of life. Most importantly, we also saw that patients that had reflux going into the procedure, we saw an improvement in reflux. So unlike a laparoscopic sleeve gastrectomy, where we typically see reflux worsen, or we even see maybe about a third of patients develop de novo reflux, we saw an improvement in these patients. Now, this was all subjective. We sent GERD HRQL to all of our patients before and after the study, but they did tell us subjectively that they were better. This is a device that was used. I would say that the nice thing about this device is that you see what happens when surgeons and gastroenterologists get together, because this was a device that was developed by both surgeons and gastroenterologists, just a lot like this study, actually. And when we get together, good things can happen. So this device is a very versatile device. So it's not just used for endoscopic sleeve gastroplasty, but we use it to close fistulas. We use it to close defects. We use it to suture stents. We use it for, a lot of different things. So it's a device that is, again, very versatile and probably a good one to have, in my opinion, if you're a surgical endoscopist. Now, the suture patterns have evolved when we first started doing endoscopic sleeves. Now, this is prior to the MERIT trial, which, by the way, was published in Lancet about 2 years ago now. And so you can read it if you want to see the details of the study. But prior to the MERIT trial, there was a lot of different suture patterns that were used. As you saw, the very first one that was described by Dr. Abudia was just taking basically anterior and posterior and just pulling it together with 2 bites, one on each anterior and posterior side, and then coming a little bit more medially and doing the same thing. And there were just many, many different sutures. We then evolved to a triangular suture pattern where we took anterior, greater curve, posterior. And that was how we did it for a few years. But what we argued, we used to sit at tables at meetings, we would get together and argue about what are the right suture patterns that should be used. And they're actually very entertaining to see people feel so strongly about a suture pattern with absolutely no data behind it. So I asked, one of our partners is another minimally invasive surgeon who does a lot of foregut endoscopy bariatrics. He was our fellow a few years ago, Mason Hedberg. He's a brilliant guy. He got an engineering degree during medical school, biomedical engineering master's. And so I just said, this is perfect for you. Why don't you figure out what suture pattern is best? And so what he did is he actually got developed a bunch of gastrojejunostomies with ex vivo porcine stomachs. And then he did the suture patterns that you see there: simple interrupted, figure of eights, purse strings, a hairpin where you kind of are going back and forth. And then what he would do is blow the stomach up and see, what would be the burst pressure there and which suture pattern held the most. And what he found was that the purse string and hairpin were actually the best at holding high pressures. I think actually when I look back, we were very naive and stupid. I mean, it's very easy to think about the more bites you take, then the less pressure each individual bite has to withstand. So if you only take an interrupted bite, both those bites take a lot of pressure. Whereas if you take about 8, 9, 10, or 12 bites in a purse string fashion, then each bite is taking, that pressure divided by 12. And so he found that the hairpin and purse string were best. Now the hairpin, it just turns out to be a little bit more difficult, but to do in the model that he used, but in the endoscopic sleeve in the stomach model, it actually works very well. And so we then started using U-stitches and seeing a difference. Now, EGJR or TOR, these are revisions. So these are revisions of patients who had gastric bypasses and then regained weight. And so what we looked at is when we went from purse string to, simple interrupted to purse string, did we actually see a difference in weight loss? We actually did. As you can see here, the solid line is the purse string sutures and the other is the interrupted. And we saw a significant difference in weight loss actually in those patients. And so we started applying this to the endoscopic sleeve, and it's actually still the suture pattern being used now. So it's, you take a first bite here anteriorly, you work your way down the greater curve posteriorly, as you see here, and then you come back around almost like a U. So it's kind of like a hairpin. So you're coming down and then back up and around. We call it a U-shaped suture pattern. And that's actually what we still do to this day. And it has really resulted in more durable and better results than the triangular suture patterns that we used before. This is just a video, just kind of a quick video of what it looks like here on the inside. So down at the bottom left, that's a helix device. So it pulls the stomach in. And I think what's most important about this device and what we really train those learning this procedure as being probably the most important part of this procedure is that you have to get full thickness bites. You have to have serosa to serosa or else it won't be durable. Mucosa to mucosa will just not last. And so there are certain things that we do. First of all, keeping the device far away, not being too close so that we can pull more tissue in. And then secondly, you can actually feel when that needle is popping through the serosa. If you don't feel a pop, then that's a mucosal bite. We will actually still take that bite, but we'll go right next to it and make sure that we actually get serosa to serosa apposition or apposition. So here you can see now we're kind of approaching the posterior part of the stomach. This procedure takes, for an experienced person, maybe about 45 minutes to 60 minutes. For like a trainee, usually we plan for about 90-minute procedure for someone doing it, but it's relatively quick. All of these patients go home the same day. They have very minimal pain. It's not pain-free. They do feel these bites in the stomach, but it's nothing like even a laparoscopic procedure. We don't need blocks. Unfortunately, this is the only bariatric procedure that we do that it has same-day discharge. Unlike, sounds like what you guys do here, you get everybody home same day, regardless of what you do. I hope to change that. But in any case, you can see now we're finishing the U-stitch. We're back on the anterior part of the stomach. And what we're going to do, actually, this procedure, by the way, is a great way to learn how to use a suturing device because there's so many repetitions. The fellows pick this up very quickly, but you can see here now, here's kind of the end. If you do a sleeve gastrectomy, you can see it looks kind of like a sleeve at the end there. Now, it may not look like you're doing much on the inside, and so I like this. This video, sorry about that. This video I think is impressive because when we look at an ex vivo stomach, it looks more impressive to me than it does on the inside of what we're actually accomplishing in terms of restricting the stomach. I tell patients that we're restricting or we're decreasing the volume of the stomach about 80%. And so we see about an 80% decrease in the stomach size. Did I break something? Oh, okay. So you can kind of see this is actually not the exact same device. This is another type of suturing device, but it's very similar in terms of, using a helix, pulling the tissue in, getting, as you can see here, serosa to serosa. So this needle goes outside of the stomach and back in. Now it goes outside of the stomach, but not enough that we worry. I've never seen a splenic injury, for example, because that's one thing that we all worry about as surgeons. We see it from the outside. I think people that don't have our viewpoint maybe don't think about the fact that there are some, important structures just on the outside of the stomach. But in 7 years, I've never transfused anybody. We've never had any injuries. I've had, honestly, just one complication out of several hundred, and that would be a perigastric abscess. And I know what I did wrong. We had a suture break. And so when you think about it, if a suture breaks, if you don't make sure to be near that area, again, when you take the next bite, you'll have a little perforation. And so, she didn't get sick, but she came in, she didn't look great. We scanned her, she had an abscess, we had to drain it. And she did fine after that. And so this is a low complication rate procedure. So hopefully you saw that suture was full thickness and all the way out of the stomach and then back in. And here you have serosa to serosa. So as part of this study, some patients were asked if they would volunteer to have blood drawn to see if we could understand a little bit more about the mechanism of how this works. As we know in bariatric surgery, it's not just about making the stomach smaller. That's a part of it, but we know that there are some satiety hormones and hunger hormones that are involved. And interestingly, what we found, not expecting this, but what we found was unlike or opposite of a laparoscopic sleeve, which by the way is a treatment for gastroparesis, if you don't know that already, the endoscopic sleeve does the opposite. So an endoscopic sleeve and a lap sleeve have a different mechanism, which is interesting to me. We think it might be because we can't really retroflex enough and get the entire fundus down. And so there's some accommodation there. And actually what we have is when you have accommodation in that fundus, that decreases the or increases the satiety hormones, as we saw here. So this was the same patient group, the randomized group, those getting diet and exercise alone versus getting the procedure. We saw a longer gastric emptying time in the sleeve group. versus controls of about, almost 50 minutes, actually. So close to an hour difference in gastric emptying time, with a much longer gastric emptying time in the endoscopic sleeve group. And then we saw an increase in GLP-1 and PYY, which are satiety hormones for those that are not familiar. We did see ghrelin also increase, which would be kind of counterintuitive. We would think ghrelin would actually go down, but it actually was increased. But I would just tell you too that ghrelin is a weird hormone. We see difference. It doesn't always do what you expect it to do, but the GLPs and the PYYs actually did do what we expected them to do, and they were significantly increased in the group that had the sleeve. So now the question is, will it fail? And I think that this video kind of exemplifies it. So if you think of this bull as being morbid obesity and really hurting the patient, and then the patient has an endoscopic sleeve and is better, losing weight, are we going to be okay forever? No, we're not. So that's what we wanted to know, is that a durable procedure? Well, I will tell you that there's still kind of a lack of data. Reem Shariah, who's a gastroenterologist in New York, has published the best 5-year data, which shows pretty significant durability, actually. So even out to 5 years, we're seeing that weight loss persist. And so that's very encouraging to us. When I was actually, at SAGES, when I was here in the spring, my partner Mason, who didn't come, he had actually just had a baby a month prior, so he stayed home this year from SAGES. But he sent me a picture and he said, one of your patients that you did a sleeve on, through endoscopic sleeve, 3 years ago, came back with abdominal pain. We got an ultrasound. There's no gallstones, but so I scoped her just to see if there's like an ulcer or gastritis or something. And he said, you'll be very excited to see the picture because it looks great 3 years later. And so I kept this picture here. You can see that the sutures are kind of even starting to fall out, but it's scarred down in that sleeve configuration. So again, 3 years later, it looks good to me. It looks like somebody who had a lap sleeve. So the other question is whether or not ESG burns a bridge. This is a big one. So there are some, I would say, surgeons in particular out there who are, maybe concerned that this might be something that eats into their practice or takes away patients from their practice. And so there have been some reports, and I myself have had to convert 2 people, one to a sleeve, one to a lap sleeve, one to a lap bypass. And it doesn't burn a bridge. As a matter of fact, if somebody is regaining weight and you look in, most of the time it's not that picture I just showed you. It's usually the sutures have come undone. And it almost looks like, the original stomach with the sutures way out, away from where you would be stapling. Having said that, you can cut the sutures out if you need to, no problem. It's a completely reversible procedure, actually. There's a nice video by, again, Barham at Mayo that shows just cutting through. There's some scar over the suture, but you can see where they are and you just can cut it. It's not a problem. So you can convert it. It does not burn a bridge. And speaking of bridges, so I think that this kind of is representative of where we are in surgery in many ways, especially minimally invasive surgery. So if you've not heard of the Choluteca Bridge, it is a bridge in South America. And it was built by the U.S. Army Corps of Engineers. And the reason why was this is an area that had hurricanes annually. And when hurricane season came, it would shut the economy down completely, because the economy was completely dependent on trucks in particular, and those bridges getting through the country. And this is Honduras, by the way. And so they asked the U.S. Army Corps of Engineers to help build a bridge that would withstand the hurricanes. And so they did. They built this bridge, and it actually lived up to expectations. So it was an incredibly strong bridge. And Hurricane Mitch, which you probably don't remember, but Hurricane Mitch was a huge hurricane that hit several years ago. And it wiped out actually every bridge again in the Honduras except for the Choluteca Bridge. So it worked. The problem was that the hurricane was so strong that it actually moved the river. It actually changed the environment. And I think that this kind of represents, as I mentioned earlier, bariatric surgery is that river. So the bridge. So we have bariatric, we're sending people home same day. We have a morbidity rate that is 2%, same as a lap chole. But yet the environment is changing. Patients still don't want that. The patients want to have an endoscopic incisionless procedure. They want to have less pain. They want a procedure that is, even though we've risen to the occasion and built a strong surgical bridge, if you will, it's not necessarily what the environment wants. And so I've lived through this personally. This is my family, Anthony, my 17-year-old son, my 15-year-old daughter, Sophia, and then my wife, Renee there. This happened a couple months ago. So she actually just very healthy out of the blue, started having headache and mental status changes. And I wasn't home. I was giving a talk. And my kids called 911. And she was taken to the hospital. And they found, unfortunately, that she had ruptured a cerebral aneurysm. And obviously this distressed us all. We spent 8 days in the ICU at our hospital. But this is actually the day that we got home from the hospital. You can see that one of the neural monitors kind of, caused a bruise on her forehead there. But this is 8 days. This is the 8th day after it happened. And what they did was they went through her ulnar artery and they embolized and stented, the aneurysm. And she woke up from that procedure and was completely fine. Back in the old days when I was an intern in general surgery, I had to rotate on neurosurgery. So this would have been back in 2000. And we saw cerebral aneurysms quite often, and we would do a craniotomy and we would clip the aneurysm. And those patients were not the same. As a matter of fact, the saying in neurosurgery is, once you open the brain, it's never the same. And so those patients looked different, they acted different, and not just in the hospital, but even at their follow-up appointments, and even sometimes when I would see patients who were 6 months out. And this was completely different. So because they kept the head closed and they went through just like we would do for endoscopy, she's completely fine. She will step back, recently, but not neurologically. And so I really think that we have to continue to move the needle and treat patients as less invasive as possible, with still obviously very, good and adequate techniques to take care of the problem. But I was incredibly impressed at the results of this. And I also learned too, the neurosurgeon that we had, who has an outstanding reputation at our place, being on the other side, I would just also say that, the caring that he showed. He would sit down, he would show us the scans, he would tell us about the options, he would listen. I learned how important it is to not just be technically skilled, but to actually be a good doctor and be really good to your patients. And so I don't think we could have gotten better care anywhere else. It sounds like you have pretty good neurosurgery here, though. But she really did great. And not only that, but the entire stay in the hospital was wonderful. So in conclusion, is endoscopic sleeve gastroplasty ready for prime time? I would say it absolutely is. It's here to stay. It's a good procedure. If you're considering doing it here, I would absolutely, with very strong confidence, tell you that you're going to be happy with it. Ann Rogers, who's the current president of ASMBS, the Maine Bariatric Society, and then Eric Pauli, who actually was one of the speakers here a few years ago, wrote an article in GIE, which is a gastroenterology journal, asking this question. But what they focused on here was the importance of not forgetting multidisciplinary care. And their concern was that people that maybe have not been doing bariatric surgery were going to start just doing a procedure but not taking care of the entire patient, which we know in bariatrics, you have to approach these patients in a multidisciplinary fashion. It's not just about the procedure. You have to make sure that you're addressing the psychological concerns, that you're also addressing the dietary concerns and lifestyle changes and all of that. And so I agree with them. This is not just something that should be done as a procedure, but also should be as part of a program. And if it's done in that way, just as we've learned in bariatric surgery, then the outcomes are going to be excellent. So I really appreciate the opportunity to be here, and I'm happy to answer any questions anybody has. So thank you. Open the chat.
Wow. Thank you so much for talking to us about endoscopic sleeve gastroplasty. I think it's super inspiring. I see a lot of the residents here sort of like wondering how they can get in on this. I know Aziz probably wants to. And I will try. If you have questions, you know, you can put them in the chat or raise your hand or whatever. I'll try to monitor, but we'll take questions from the live people here. Dr. Feldman.
Great talk. I guess the main question for me would be, is this sort of like shockwave lithotripsy was for gallstones before Lacoli? And I would think that the real competition would be GLP agonists.
Yeah.
And how is that, you know, what you're looking for, you know, I understand there's no long data, et cetera, but for patients, is that coming up in your discussions about the options and how are bariatric roles incorporating?
Yeah, great questions. I assume everybody can hear the question. If not, I'll just repeat what Dr. Feldman asked. Was really about obviously the weight loss medications, which are very popular right now. And I have a lot of different thoughts on that. I think there are a couple of different ways to look at it. I think number one, I also treat gastric cancer actually. And I think about, you know, one modality to treat esophageal cancer or gastric cancer is typically not effective, even just surgery alone. So we have neoadjuvant therapy, we have adjuvant therapy for esophageal cancer, we have triple therapy with radiation as well. And I think that we should be approaching obesity, morbid obesity in this very same way. So one modality, why do one modality if you can do two? So a lot of our patients, and actually there's increasing data now showing that if you treat patients with one modality alone, if you just treat them with a GLP-1 agonist, or you just treat them alone with an ESG or even a lap sleeve, they won't have as much weight loss as someone who's being treated with multiple modalities. So for example, Ozempic plus an ESG, they do lose more weight than they would with either alone. So that's one way to look at it, is like, let's not pit them against each other. Let's talk about using them together, just like we do for a lot of cancers. I think the second way to look at it, and again, I do a lot of anti-reflux surgery. I think those drugs are a lot like a PPI. I mean, they're very effective. You do have to continue them forever. And there are a lot of patients that don't want to continue a drug forever for a variety of reasons. Cost, they're very expensive. And just being on a medication the rest of your life, again, if you stop those drugs, your weight comes back. And so this is a more, I would argue, a durable option than the drugs. And so I don't want to pit them against each other because I think they're more complementary. But the drugs alone, though, we're kind of in that honeymoon phase right now. There's more and more coming out about side effects. They're acceptable, but there's still some side effects. There's some patients that are not going to be able to have it. I don't know where we're going to fall in the United States with insurance. A lot of insurance will not cover them. And it's the same issue. They realize, too, that once they start covering and seeing those results, it's great. We have weight loss, but they're going to have to continue that forever. So now which is better, getting them off their diabetic medications, which we know medically what's better. But from a business person's point of view, you're paying for a more expensive drug. They have to be on lifelong. That's how I feel. The drugs are great, and we use them all the time, but they're not the all thing that a lot of people want to think they are.
Yeah. Can you stop the share? Or if you want,
stop the share.
take this to answer, and then I can maybe
Sure.
Does that work for you? Go ahead and ask. Yeah.
I Ujiki. I noticed the key infection. There's less risk of reflux. Why do you think that is?
Yeah, I think it's a different mechanism than like a lap sleeve. We don't have the high pressure zone. The lap sleeve, when we do those, we are hugging, that bougie going all the way up to the GE junction. An endoscopic sleeve, we cannot retroflex enough with the current technology to really completely get the fundus, sutured down. And so when you look at those, I didn't show them, but if you look at the images of the gastric emptying studies that we did on those patients, there's a lot of activity actually. I showed you that it's about almost an hour longer gastric emptying time. there's a lot of activity in the fundus, actually. So we call that accommodation. That fundus is accommodating all that food and liquid up there. And so we don't have accommodation with a lap sleeve. You know, it's just a very high pressure, pouch, if you will. And so I think that puts a lot of pressure. It's almost like, not quite, but I have to bring everything back to the foregut. So it's kind of like achalasia, pseudo-achalasia almost. And whereas this is not. So I do think that that's why we don't say, we don't know, but that's probably why. And remember too that a lot of patients have reflux because of the increased abdominal pressure from their weight. And as we lose 50% of their excess weight with this procedure, we see an improvement in reflux from that alone. So I think that's probably weight loss helps, and also the accommodation of the fundus.
We have a comment in the chat here from Amin. I have one question for you. In the ESG, especially when performed by GI, there's always almost remains a retained fundus, especially because of what you mentioned in the retroflexion to put good stitches or damage the spleen, etc. And in lap sleeve, of course, one quality metric is complete fundal resection and its impact on post-op GERD and poor weight loss if not done. Any comments on that? Do you see a significantly higher GERD compared to your sleeve gastrectomy patients?
Yeah,
That
good question. Yeah, and this is almost universal. When I give this talk to surgeons and GIs, the surgeons will always bring this up. You know, as surgeons, we are so concerned and about getting that fundus taken care of, whether it's a sleeve or a bypass. We really want the fundus out because we've learned over the years that the fundus is a bad problem and we got to get rid of it. And again, here with the GIs, and again, I've been in rooms, the same arguments back and forth, in terms of suture patterns with everybody, but also with the fundus. And but the proof is kind of in the pudding. I think first of all, it's a different mechanism, and so we can't create as high a pressure in the stomach with an endoscopic sleeve like we do a lap sleeve. I mean, just being in there suturing, we can't. It's not like hugging a 40 French bougie. So we don't create as high a pressure in that stomach like we do in a lap sleeve. If we did a lap sleeve like this where we hug the bougie, but then left a portion of the fundus, which by the way we still suture most of the fundus down. It's just the very top portion of the fundus that we just can't get in retroflexion. But if we were to take that stapler and hug the bougie all the way up and then leave a portion of the fundus, it would be a bad outcome for a lap sleeve. There's no question. But here, I think it's just a little bit different mechanism. We're not able to create as high a pressure, probably why we don't have reflux, and probably why that accommodation works in an endo sleeve and not. I mean, I can't argue the results, and we probably still don't know everything about both problems. We don't understand reflux completely in a lap sleeve. We think we know. In an endoscopic sleeve, I'm not sure we completely understand why it doesn't cause it. Reflux at the same level, but that's what we think, at least. So, and Amin, thank you again for driving me around. He took me on a nice tour on the way home from another great restaurant on Tuesday night, and so I'm forever grateful. And remember, I promised you come to Chicago, and I'll make sure that you're taken care of there.
Aziz.
Thank you, Dr. Ujiki. We are lucky that we discussed the endoscopic sleeve in our graphic last month, and the discussion at that time was two groups. People they believe that the weight loss will affect the reflux to go down, and I don't understand what we do to keep it from the down. My question is, do you, because like when we consult patients in the clinic, but if a person is sleep, we don't immediately off. Now, a patient will get go for endoscopic sleeve, and he might have a hiatal hernia. We do a workup before that to make sure he doesn't have it. Because I know the intragastric balloon, they don't do it for hernia on the and they have a workup. So do you work up these patients? And the second question is about, because we do scale procedures like at the NPS, we start with the patient lose weight and we plan on the stadium after that. Do you think the endoscopic sleeve can be a part of the stadium?
Good question. First of all, you can see the PTSD from bariatric surgeons with GERD and lap sleeves. I mean, that's it. It's always this, question about GERD. But the good question about hiatal hernia. So in the study in the MERIT trial, if you had a 4 centimeter hiatal hernia or less, it was okay. And I've always been a little bit like, again, coming from an anti-reflux kind of position here, always been concerned about that. But I will say that we had a couple patients at our own center with hiatal hernias, and they did okay. They didn't have problems. That's anecdotal, obviously. 2 patients don't make a study. But right now, unless you have a pretty large hernia, which I would say over 4 centimeters, we would still do it. We do not get preoperative imaging. We tell the patients that we're going to obviously start with an endoscopy. And if you have a large hiatal hernia, then we're not going to proceed. And we have had to do that a couple times where we just, had to cancel or abort the case and just didn't do it. But anybody with 4 centimeters or less, we're doing it, and we haven't seen any problems from that. And in terms of revision, absolutely. There's no reason why you can't do, convert this to a SADI later. No reason at all. It's the same paradigm, actually. Now, I personally have not done that. So I haven't done that. I have, as I mentioned earlier, I've converted a couple people to other procedures like a lap sleeve or a bypass, but I haven't converted someone to a SADI. Now, we should probably think about doing that like we think about revising a sleeve to a SADI, a laparoscopic sleeve, but we just haven't. I haven't had that experience yet, but there's no reason why you can't do it.
So I don't see any more questions in the chat. I don't know if anybody in the audience has any more questions. I think, as I was listening to you, it made me think about like this concept of innovation, where you're right that as surgeons, sometimes, like we spoke yesterday about like how the myotomy has to always be, the 2 centimeters on the cardia and the 6 centimeters. And that, like, we're sometimes so stuck to that dogma because it seems a little bit like part of our culture in a way. And so, I think bringing up a good point here is that like we've always done that and we've based it on studies, but there's always limitations to all of those things, right? And we have to kind of keep an open mind. Like maybe it isn't the complete truth. Like maybe we don't actually understand this 100%. So let's give this a try and let's look at it from a different angle. And, maybe there is a way that we can do this differently and still get a good outcome, still have, and it does seem to be challenging for us as surgeons to do that, right? And I think it comes from a good place, right? We want to have a good outcome for our patient, et cetera. But like, we also have to have a little bit of cognitive flexibility, I think, there. So
no question. And I saw a lot of that yesterday with your group. I mean, that, just challenging the norm, sending people home the same day after a colectomy. I mean, that blows my mind. I can't wait to talk to our older surgeons back home. They are going to freak out. Just getting them to do ERAS was a struggle. Now we're talking about going home, but you have to keep doing that. We have to challenge those dogmas. That's our job. So thank you very much. I really enjoyed this day. Thank you.